Hi, everyone. Thanks very much for the invitation to join you all today. I'm sorry that I'm having to record this talk and I'm not there live in person, but I hope it's still a useful talk for you all. So my name's Neil Patel. I'm a neonatologist here at the Royal Hospital for Children in Glasgow. And the title of the talk that I've been asked to give is Hypotension in Newborn Infants. And hypotension or low blood pressure, of course, is a problem that we frequently encounter in newborn infants in the neonatal unit. But I actually feel like we shouldn't give this title to the talk. And I'm going to explode that title, and I'm going to give another title to this talk instead. And hopefully by the end of the talk, you'll understand why I've done that. So instead, I'm going to call this talk Cardiovascular Assessment and Therapies in the Neonatal Intensive Care Unit, because I think the approach of thinking about wider cardiovascular assessment and targeted treatment is much more appropriate than thinking just about blood pressure alone. And I'll explain why. So what I'd like to cover in today's talk is some of the basic physiology of the circulation, the components of the circulation, and the concept of oxygen supply and demand within the body. And building on that understanding of the physiology, we can then start to think about what are the best measures of circulation function. And blood pressure may be one of those. And we can also then talk about choosing cardiovascular therapies and the different actions that therapies have. And then I'd like to end with a few example cases, and I know you're going to discuss some more later, but just to show this approach. So the function of the circulation, of course, is oxygen delivery. It's there to get oxygen from the lungs to the tissues to be used for aerobic metabolism and energy generation within the tissues. And of course, oxygen delivery is dependent on oxygen content of the blood. And as you all know, oxygen content of the blood depends on hemoglobin concentration and the oxygen saturation of that hemoglobin as well. So oxygen content is going to be an important factor in circulatory function. The other component that will determine oxygen delivery is how quickly that blood containing oxygen is getting to tissues. In other words, the cardiac output, how many mils per minute of oxygenated blood are getting to the tissues. And if we think about what determines cardiac output, of course, it's determined by stroke volume, the amount of, or the volume of blood that is ejected with each heartbeat, multiplied by the heart rate. And stroke volume itself is determined by the inherent myocardial function, the ability of the ventricle to contract, or its inotropy, but also its ability to relax, or lusotropy, that's its diastolic function. And we often forget about that diastolic function and just talk about myocardial function in terms of contractility. But if you think about it, contractility is just as important as the diastolic function or lusotropic function. And stroke volume is also determined by how much blood is filling that ventricle. The preload, remember the Frank-Starling relationship? To a point, the more blood that the ventricle is filled with, the more it will eject. And that's the concept of this relationship between preload and myocardial function. And the other thing that will determine myocardial function is the afterload on the ventricle, the pressure or resistance at which it must work against. And for the systemic circulation, the systemic vascular resistance is determined by peripheral arterial and venous tone. And you might look at this and say, okay, that's great, but what about blood pressure? And I think that's a really important thing for us to stop and think about. Here we've described the function of the circulation and the components of the circulation that determine oxygen delivery, but blood pressure isn't one of those. And of course, blood pressure is the product of cardiac output and systemic vascular resistance. So in some ways, blood pressure is a composite measure. It doesn't tell us about the individual cardiac output or the systemic vascular resistance directly, but it's dependent on both of those. And I know that this is basic physiology that you may have learned many years ago, but it's also physiology that a lot of us forget at the bedside. And I stress it here now, because I think if you can remember this this image, remember where blood pressure is derived from, and remember what the function of the circulation is, then in any situation, we can make a much better assessment and targeted decision about which therapies to use. And that's what we're going to come back to talk about later on. Okay, and this slide is just to show the relationship between blood pressure and cardiac output. Remember, cardiac output is an important determinant of oxygen delivery. And it just reinforces that the fact that the relationship between blood pressure and cardiac output is not linear. And this was data from a group of premature babies studied by the group of Nick Evans and colleagues in Australia. And what they did here is they plotted blood pressure. So they said that in these babies who had a gestation of around 30 weeks, they used a mean blood pressure of 30 as a cutoff. And of course, that's traditionally what we do in all infant populations. We use mean blood pressure in weeks of gestation as a cutoff for normal blood pressure. And what you can see is that they also plotted cardiac outputs, and they said that a normal cardiac output was above 80 and an abnormal one was less than 40. And here you see in this pink quadrant, a group of babies who have a normal mean blood pressure, but have a low cardiac output. In this quadrant up here, the babies have a normal blood pressure and a normal cardiac output. And in the quadrant down here on the left, the babies have a low blood pressure and a low cardiac output. And what's important, particularly about this segment in the top left in pink, is that in these babies, if we only looked at blood pressure alone, we would not necessarily identify that they had an abnormal cardiac output and therefore abnormal oxygen delivery. And of course, the reason why they have a normal blood pressure but a low cardiac output, if we go back to the previous slide, is because they almost certainly have an elevated systemic vascular resistance. I want to also highlight the importance of looking at the systolic and the diastolic blood pressure, as well as just the mean blood pressure, and how looking at the difference between the systolic and the diastolic, which is the pulse pressure, can help us to make some assessment of cardiac function. So here are 3 blood pressures in 3 different babies, and they all have a mean blood pressure of 40 millimeters of mercury. If you look at the first one, the pulse pressure here is 34 millimeters of mercury, so it's really very wide, which is a sign probably this baby has good cardiac function despite a slightly low diastolic pressure. The second blood pressure here, you can see that the difference between systolic and diastolic is 15 millimeters of mercury, which is within normal limits, but with a higher diastolic pressure. And then in the final blood pressure, you can see that the baby has a difference between systolic and diastolic of just 6 millimeters of mercury. And that's clearly consistent with a low cardiac output, possibly due to a low cardiac function. And this baby has associated with that a high diastolic pressure, which has driven up the mean. So you can see we have a difference here between one baby who's got probably very good cardiac function and one who's got very poor cardiac function or low pulse pressure, but the same mean blood pressure. So the message is, look not just at the mean, but at the systolic and the diastolic to make some assessment perhaps of cardiac output and cardiac function, and also of diastolic pressure as a measure of systolic vascular resistance. I want to also talk about the pathophysiology of oxygen delivery and oxygen consumption. In the normal state, the amount of oxygen delivered by the circulation exceeds the oxygen consumption in the tissues. So the DO2 exceeds the VO2. And therefore, the oxygen extraction, or the amount of oxygen that the tissues take out of the blood, is only around 20 to 30%. That's why if you have 100% saturated arterial blood, venous blood returning to the heart is probably around 70% saturated. However, in a situation where there's increased oxygen consumption or increased oxygen demand, for example, in sepsis, then the oxygen delivery and the oxygen consumption may start to level out. And that is possible because oxygen extraction can increase without necessarily needing an increase in oxygen output, or the cardiac output may be able to adjust as well. However, if there's a situation where the oxygen consumption increases and the oxygen delivery and is not able to meet that, for example, low cardiac output or low hemoglobin, then two things will happen. First of all, the oxygen extraction will increase even further, and for that reason, the venous saturations will be even lower. But also the tissues will be hypoxic and will switch to anaerobic metabolism and generate lactic acid. So in that situation of insufficient oxygen delivery, we will see low venous saturations and acidosis, lactic acidosis. And we can use both of those as measures of systemic oxygen delivery, and therefore as proxy measures of cardiac output and systemic blood flow. So let's come back to our diagram here. What we've been discussing is the importance of cardiac output and oxygen content as determinants of oxygen delivery. And we've been talking about how the balance or measures of the imbalance of oxygen delivery and oxygen consumption can be used as proxy measures of cardiac output, in particular lactate and systemic venous saturations. The next thing I'd like to talk about is how can we assess the circulation in every patient? And ideally, if we want to assess the circulation, we want to assess all of these different components of the circulation. So let's talk about how we might do that in a neonate. First of all, oxygen content. Well, we assess that routinely. We look at hemoglobin concentration, we look at the oxygen saturation, and if we've got an arterial blood gas, we can look at the partial pressure of oxygen in the arterial blood. We can measure blood pressure, of course, and that's how we define hypotension in a baby. We can do that invasively or non-invasively. And again, of course, it's a routine measure. Heart rate and rhythm are important. Remember, heart rate will determine cardiac output. And we typically measure those using a non-invasive ECG, and that's routine as well. What about cardiac function? Remember, we talked about myocardial function as a determinant of cardiac output and oxygen delivery. Well, we can assess the cardiac function in some way by looking at the blood pressure, by looking at the pulse pressure. Remember those three different blood pressures that I showed you? And if the pulse pressure is normal, I would say above 10 to 15 millimeters of mercury, then that's a reasonable sign that you've got good cardiac function. But if the pulse pressure is low, less than 10 millimeters of mercury or 5 or less, then I would be significantly worried that the baby had impaired cardiac function. Of course, another way we can assess cardiac function is by visualizing the heart using echocardiography. And that can be desirable if it's a measure that's available to you. And here you see one of the techniques that we use to assess cardiac function using just a 2D loop obtained by a 4-chamber window of the heart. It's inverted here. You can see the left ventricle and right ventricle. And even that 2D visualization of the heart gives us some way of assessing function, albeit subjectively and non-quantitatively. So it's qualitative assessment. There are other techniques that we can use to quantify cardiac function by echo. You may have heard of fractional shortening and ejection fraction. And there are other techniques we can use as well in neonates. What about cardiac output? Well, measurement of cardiac output is almost like the golden solution that we would love to have in neonates as in any population. But unfortunately, it's not something that we can easily and routinely measure in newborn infants. There are ways of measuring it by echocardiography, but it's prone to error, and it's not a reliable technique that's used widely in neonatal practice. Sometimes people will use clinical examination as a proxy measure of cardiac output. Here you can see measurement of capillary refill time, something that we use and report very often. However, when there have been studies performed to look at the relationship between capillary refill time and cardiac output in newborn infants, again, here in a group of preterm infants where a cardiac output of 40 or less was considered abnormal, you can see that there are a group of infants who will have normal capillary refill time. Here, that was said to be less than 3 seconds, but a low cardiac output. So the inference is that capillary refill time is not necessarily a good proxy measure of cardiac output. That was also demonstrated in this study, where cardiac output or cardiac index was measured invasively in children who had central lines in place. And you can see that here is the estimated cardiac index, which was estimated by experienced clinicians, plotted against the measured cardiac index using the invasive technique. And there's very poor correlation here. We're not seeing all of the dots line up in a nice tight row, indicating that the estimated cardiac index was not reliable in estimating the actual cardiac index. What about those proxy measures of cardiac output by looking more at systemic perfusion and systemic oxygen delivery? Well, we already touched on these, and in particular the role for plasma lactate. Remember, lactate will go up when there's that imbalance of oxygen delivery and oxygen consumption, which we will see if there's reduced systemic blood flow. We can also use other measures of end organ function, like urine output, but I would say that that's a late sign and not a good one. And as we mentioned, capillary reflow time, although we do it routinely, is not necessarily a good measure. We also mentioned that you can look at systemic venous saturations, because if there is impaired oxygen delivery combined with increased oxygen demand, then there will be increased oxygen extraction from the arterial blood, and that will lead to lower mixed venous saturations. It would be nice to measure those routinely, but again, it's not something that we do in usual practice. What we sometimes do in our own department is use a device called the NIRS, or near-infrared spectroscopy, which looks not at the saturations in the arterial blood, but at the saturations in the tissues. And it correlates with those mixed venous saturations as a measure of systemic perfusion. What about those other measures of the circulation, preload and filling? Well, again, we don't have an easy clinical measure of those. Echocardiography can give us some indication of preload and filling, but it's again subjective. An alternative is to see what the response to volume is, and that's what we tend to do in clinical practice. And what about afterload? Remember, afterload on the left ventricle is the systemic vascular resistance. It would be great if we could measure that alongside blood pressure and cardiac output, but again, unfortunately, we have no direct measure of it. I did mention to you before, however, that we can use the diastolic blood pressure to get some assessment of that systemic vascular resistance. If it's very low, that may lead you to think about whether this patient is vasodilated and has a low systemic vascular resistance, or perhaps needs some volume as well. In the right heart, the afterload is pulmonary vascular resistance, and that's something we can measure echocardiographically by assessing pulmonary artery pressure. I'm not going to talk about that in this talk because it needs more time on its own. So to summarize everything that we've discussed before and take it to the clinical situation of assessing a baby, what I would say is if you suspect there's cardiovascular compromise, and that could be because of abnormalities in any of those measures of circulation, including blood pressure, then the question to ask is, where is the problem? Which of those components of the circulation is abnormal? And to do that, we want to assess the circulation using those different measures that are available to us that we talked about in the previous slides. There are the routine ones, there are the desired ones, including echocardiography, and then there are sometimes the additional ones like systemic venous saturations and near-infrared spectroscopy. And once we've made our assessment of the circulation, we're in a much better situation to understand what an appropriate targeted therapy might be. So to understand what the mechanism of low blood pressure might be, and then to choose the correct treatment, which may not be the same in every case. And I think that's a really important point. In the past, there was a tendency to think that we could treat the blood pressure or any impairment of the neonatal circulation with the same treatment, the same drug or the same type of drugs. What I would like to suggest to you today is that each baby is different, and the reason why their circulation may be abnormal can be different at different times. And therefore, the treatment we may choose may be one that's more targeted towards improving oxygen content and carrying capacity of the blood. It may be about improving intravascular volume or preload. It may be about directly trying to improve cardiac function using inotropes or lusitropes to improve diastolic function. Or it may be targeting the systemic vascular resistance, either to increasing it using a vasopressor or reduce it using a vasodilator. And then our approach should be to assess in response to our treatment and see if we've had a limited or an adequate response. And if we have, then if we haven't had an adequate response, then to reconsider a second-line therapy. So let's talk about some of the drugs that we might choose to use in cardiovascular therapy, in cardiovascular treatment in neonates. And we tend to lump all of these medicines together and call them inotropes. And again, that's where I'd like to explode our current thinking and our current practice. And I'd like to suggest to you that we need to think of the individual drugs in terms of their individual actions. So let's think about that. And we may want some drugs that act directly on the heart if the cardiac function is impaired. And we may want ones that improve contraction or improve relaxation or increase the heart rate. We may want drugs that act on the systemic circulation, as we discussed, to increase the systemic vascular resistance or decrease it. Or similarly, in the pulmonary circulation, to increase pulmonary vascular resistance or to decrease it. And in the heart, we call drugs that improve contraction inotropes. That's a very specific action that we're describing there. Drugs that improve relaxation, lusitropes. Drugs that improve heart rate, chronotropes. In the systemic circulation, vasoconstrictors will increase systemic vascular resistance. We might also call those pressors. Vasodilators will reduce systemic vascular resistance. Similarly, in the pulmonary circulation, pulmonary vasoconstrictors or pulmonary vasodilators. So what about those agents, those specific drugs that we commonly use in neonatology? What do they do? Which of those actions do they have? Well, let's start with dopamine. Dopamine is a positive inotrope and at higher doses will also increase heart rate. In the systemic circulation, it increases systemic vascular resistance, so as a vasoconstrictor. Its action on the pulmonary vasculature isn't entirely clear. There's some data to suggest it may be pulmonary vasoconstricting in preterm infants. The dose is important. I like to use 5 to 10 micrograms per kilogram per minute. At higher doses, I think that you run the risk of a positive chronotropic effect, increased heart rate, which will impair diastolic function, and I avoid that. What about dobutamine? What's the difference between that and dopamine? Well, dobutamine is also a positive inotrope, and it's also a positive chronotrope. It will definitely increase heart rate at higher doses. But the difference between dobutamine and dopamine is that in the systemic vasculature, dobutamine is a vasodilator. It will cause a reduction in systemic vasodilatation. And that might be less marked in preterm infants because they have fewer beta receptors. Again, the usual dose for dobutamine is 5 to 10 mics per kilogram per minute. I would avoid it in higher doses because it will increase heart rate and that may impair cardiac filling and output. What about adrenaline? Well, adrenaline, like dobutamine and dopamine, is a positive inotrope, but I would say it's a more powerful positive inotrope. In the systemic circulation, it probably has some vasoconstriction action. And the dose that I like to use it in is typically 0.03 to 0.05 mics per kilo per minute. I avoid higher doses because they will lead to lactic acidosis. And at that point, we need to think about other types of support for a patient. Now, noradrenaline, like adrenaline, is also a positive inotrope, but it's its real action, I would say, is that it's vasoconstrictor. And it's a more powerful vasoconstrictor in the systemic circulation than adrenaline. Again, same dose range as adrenaline. There are some other drugs that I've mentioned here. I'm not going to go into detail about them all. Milrinone is a drug that we use increasingly, positive inotrope and a positive lusitrope with some vasodilatation. It's a gentle drug. It doesn't have a very strong action, but there are some situations where it can be very useful, including in pulmonary hypertension. Vasopressin is a vasoconstricting drug, like noradrenaline, and it can be useful in situations where there's low systemic vascular resistance. Just to mention hydrocortisone, we use it quite a lot in babies who have low blood pressure. It seems to have a general positive inotropic effect, maybe particularly important in babies who don't launch a good steroid response during sickness. And we use it particularly in situations where we're needing higher doses of dopamine or needing to start adrenaline. And combinations of drugs are sometimes important and useful. So they allow you to separately control the heart and the systemic circulation. For example, there may be a situation where you want to have a positive inotropic effect of dobutamine but combine that with a vasoconstricting action of noradrenaline. Or conversely, you might want the positive inotropic effect on the heart of a stronger agent like adrenaline, but with a vasodilating agent like milrinone, or another drug that we use very rarely, really, nitroprusside, sodium nitroprusside, which is a powerful vasodilator. But there's only very specific situations where I would use that, and I certainly wouldn't recommend it if you've never used it before. And this is just a summary slide to demonstrate that concept of a first-line agent and a second-line agent. So, for example, if we have a baby where we want to improve inotropic or cardiac function in systole, we might in the first instance use dobutamine, but if we're not seeing an adequate response, think about adding adrenaline. If we wanted an inotrope and a vasoconstrictor, we might start with dopamine, but if we need more powerful pressor or vasoconstriction action, we might then add low-dose noradrenaline. Okay, let's finish off by talking about some cases just to illustrate what I've been talking about today. So first of all, a 36-week baby. In the first hours of life, there was meconium evident at birth, and now the baby's ventilated and quite a lot of oxygen, 80% oxygen. And the blood pressure is 35/20 with a mean of 27 millimeters of mercury. So for a 36-week gestation baby, I think we'd all agree that this baby is hypotensive. It's got a low mean blood pressure. But what is the mechanism of that? Well, if we do some other investigations, here's an arterial blood gas with a lactate of 3.5 millimoles per liter, so slightly elevated. And we do an echo, which shows moderate LV dysfunction. I would not say that echo was essential in this situation. I think even without the echo, you could start to get a sense of what's going on here. So here's our echo. It's a long axis view of the heart. There's a left ventricle. It's a little bit of mitral regurgitation, which produces this blue jet here. And even for those of you who aren't experienced in looking at echoes, I hope you'd agree, there's maybe a not quite normal left ventricular function here. So mild to moderate impairment, I would say. So what's going on in the circulation? Let's think about the individual components. We've got a blood pressure with a slightly low pulse pressure and a low diastolic pressure. So that starts to suggest maybe slight impairment of cardiac function and a low systemic vascular resistance. Our cardiac function was confirmed on echo as being moderately dysfunctional. And the lactate tells us that we've got impaired oxygen delivery. So what's our treatment approach? Our treatment approach is to improve that cardiac function using an inotrope and to increase the systemic vascular resistance, but only gently, because we don't want to increase the afterload too much on that ventricle that's already not functioning normally. So in this situation, I'd go with an inotrope and a mild vasoconstrictor, for example, dopamine. Okay, let's look at another case. Another baby born at 36 weeks gestation. Non-reassuring CTG, so they're born by emergency cesarean section, have low APGARs and are intubated at birth. They're ventilated in quite a lot of oxygen, 0.75, and their blood pressure is 35/30 with a mean of 32 millimeters of mercury. And their lactate on arterial blood gas is 7 millimoles, so it's elevated. Already from that blood pressure, you're perhaps getting a sense about cardiac function. And we can see that the mean blood pressure is low. So again, we'd say this baby is hypotensive. Here's the echocardiogram of this baby, 4-chamber view. And you can see that the left ventricle and the right ventricle are not contracting particularly well. So the echo is confirming what we might have suspected from this low pulse pressure, which is that the baby has got impaired cardiac function. So this baby's got a low pulse pressure with a highish diastolic pressure. The cardiac output and oxygen delivery is impaired because we've got a high lactate, indicating imbalance of oxygen delivery and demand. We've seen left ventricular dysfunction on an echo, although we already suspected it from the blood pressure. So our treatment here is to improve cardiac function. Again, we want an inotrope. But in this situation, because of the higher diastolic pressure, we perhaps want to avoid vasoconstriction. So we might choose something with mild vasodilating action. And this is where it might be reasonable to start with dobutamine. And I would, again, just to mention, avoid higher doses. If the blood pressure is not responding once the butamine's been commenced and has got up to a maximum dose of 10 mics per kilo per minute, then we might think about adding in a second agent or more powerful drug to improve cardiac function. And here I might use low dose adrenaline. Okay, last case. Preterm baby born at 32 weeks gestation. On day 7 of life, his deterioration is apneic and needs to be ventilated. Blood pressure here is 33/18 with a mean of 25 millimeters of mercury. So we've got pulse pressure here of 15 millimeters of mercury, but a low mean pressure. So the baby is hypotensive. So what do we think is going on? Let's think about the other components of the circulation. So we look at hemoglobin, that's 90 grams per liter. Look at the heart rate, 195 beats per minute, quite tachycardic. Lactate is 4 millimoles per liter, again indicating imbalance between systemic oxygen delivery and consumption. And I'm also going to show you an echo, although again, I don't think it's essential. I think you can make a good assessment of what's wrong in the circulation even without the echo. But here's our echo. Oops. It's not actually playing, but that's not a problem because what I wanted to show you was actually normal cardiac function in this baby. So what we're saying in this baby, if we look at the blood pressures, they had a good pulse pressure, 15 millimeters of mercury in a preterm baby, but with a low diastolic pressure. And that's what was contributing to our low mean pressure. We've got evidence of impaired oxygen delivery with a high lactate. And we've got confirmation of normal cardiac function on the echocardiogram. So our treatment here is not to target cardiac function because it's normal, but instead to optimize intravascular volume and oxygen carrying capacity. And in that case, I would actually give this baby some red blood cells. And we also need to think about increasing the systemic vascular resistance, because remember that that's what's contributing to a low diastolic pressure in this baby. And I would do that by using a mild vasoconstrictor, in this case probably dopamine or low dose noradrenaline. And in fact, this is the clinical picture that we might see in a baby with, for example, NEC or gram-negative sepsis, where function may be preserved, but the problem is one of low SVR and low intravascular volume. And it just highlights the importance of understanding that there are different reasons why a baby may be hypotensive, sometimes related to cardiac function, sometimes related to vascular resistance, or a combination of the two. So thank you very much for listening. I hope that that's been a useful talk and has started to make you think beyond the blood pressure alone to the other components of circulation. And I just want to give you a take-home message. And my take-home message is, remember the relationship between blood pressure, cardiac output, and systemic vascular resistance, and think about what is the mechanism of a low blood pressure or cardiovascular compromise in an individual baby at any point in time. What is contributing to either abnormality in the cardiac output and the systemic vascular resistance? And think also about the role of cardiac output and oxygen carrying capacity in determining oxygen delivery and looking at the balance of oxygen delivery and consumption. Our approach to treatment and selecting a treatment should be goal orientated. And by that, I mean targeting the component of the circulation that we think is dysfunctional. Functional echocardiography is useful, but it's not essential by any means. And our approach should be that once we've chosen a therapy based on our initial assessment, we assess the response. And if we don't have the adequate response, then think about those second line agents or reassessing the circulation to make sure that nothing else has changed. So thanks for listening. And I hope that this has been useful for you. And if you have any questions or would like to get in touch, then my email address is there. I look forward to hearing from you. Thank you very much. Bye now.